Chemotherapy-induced nausea and vomiting is a symptom that some patients experience after receiving chemotherapy. And it's definitely a concern for most patients who are going to undergo chemotherapy. In fact, that and hair loss are still the two biggest concerns that patients have in going through chemotherapy. And I think a lot of that has to do with history, in that back in the 70s, we literally would give patients buckets and say, good luck. 80s brought around high doses of metoclopramide, which got, improved things a little bit more. And then in the early 90s, we had the introduction of a new class of antiemetics that really started to change the game. So the expectation of nausea as something that was normal or occurred and was just something patients had to suffer through has really changed over the decades. We now have standard ways that we pre-medicate patients prior to getting chemotherapy based off the type of chemotherapy they receive. And in very broad terms, we take the chemotherapy and we place it either at high risk, moderate risk, or low risk of having nausea and vomiting. And then based off of the risk, rather than wait for patients to get nauseous after they get chemotherapy, we give medications prior to try to avoid the entire experience altogether. And so based on standard guidelines through the three agencies that help us establish these practices, we give a combination of 3 drugs for highly emetogenic chemotherapy prior to receiving their chemo, 2 drugs for moderate emetogenic chemotherapy, and sometimes we add a 3rd. And then in low risk, we usually just add a steroid or as-needed medication. In thinking about how we prevent and then treat nausea, we have to think about what causes nausea. And it's important to remember that having nausea and vomiting is a very important mechanism that helped us evolve over time and to avoid things that were completely noxious. So the neurotransmitters that we typically think of are serotonin, and serotonin has multiple subtypes. We think about serotonin being mostly in the gut. There are cells that line the GI system called interchromaffin cells that are primarily responsible for secreting serotonin, but we also know it plays a major role in the brainstem. Another neurotransmitter of key importance is dopamine. Dopamine, specifically dopamine type 2 receptors in the brainstem, are a target for treatment and prophylaxis. Other drugs that we have that help focus on substance P, and these are our neurokinin 1 antagonists, and this is the latest and greatest drugs that we have available. Now there's also histamine. We think of acetylcholine, GABA, so some of the benzodiazepines that interact with GABA. Steroids obviously play a big role. How those work exactly is a lot of hand waving. And then fairly common in the news now are cannabinoids and the role of cannabinoids in not only prophylaxis but treatment. So it's a mixed bag, but in chemotherapy-induced nausea and vomiting, we have great evidence to support the use of the 5-HT3 antagonists, the NK1 antagonists, and of course steroids. The validated tools that we use in assessing chemotherapy-induced nausea and vomiting include the MASK anti-emesis tool, which can be used in 24-hour increments, which helps in its flexibility when you're looking at multi-day. The other tool that we use is something called the FLIE, or the FLIE, which is FLIE, the functional index of living and emesis, which has 3- and 5-day recall. Proactive communication, with regards to chemotherapy-induced nausea and vomiting is incredibly important at this time, because there still is this lingering belief that nausea and vomiting is to be expected when you're getting chemotherapy. And it really doesn't have to be that way anymore, given the tools that we have. So I think it's incredibly important to sit down and talk to your patients about this great fear that they have, and let them know that we have established tools to avoid the entire experience altogether, or if they do have nausea and vomiting, to treat it effectively.